Hey, welcome to another episode of Talking with Docs. Today we're talking about Uranus. And I don't mean the seventh planet from the sun, aka third largest in the solar system, like your hat says.
Right here.
We are talking about things that can go wrong with your anus, such as hemorrhoids.
And particularly the surgical side of hemorrhoids. We have some other videos to talk about the non-operative side, but we brought in a special guest, Dr. Choi, a colorectal surgeon, to talk all about hemorrhoids and the surgical treatment of them. Welcome, Ian. Thanks for joining us.
Thank you very much. Thanks for having me.
I think we should start right at the beginning. We're going to cover this topic top to tail. Stick around till the tail end, so we'll put a good summary for you. But what is a hemorrhoid?
Well, what a lot of people don't realize is everybody has hemorrhoids. You have hemorrhoids.
What?
You have hemorrhoids.
I got hemorrhoid?
Hemorrhoids are completely normal.
I got to
Okay.
go see my
Right.
doctor.
They're all there, and they actually serve a function.
Okay.
They're blood vessels that sit at the top of our anal canal, and they swell up, and they help to prevent leakage of mucus and stool out the bottom end.
Okay.
Now, what happens though is that if you're not getting enough fiber and fluids in your diet, as the stool is going through the area, it pulls and stretches on those blood vessels and they start to prolapse down out through the anal canal. And that's where we start to get problems with hemorrhoids, with like bleeding, pain. With that mucus leakage, you can get irritation, itchiness, and scratching and bleeding from that as well.
And that's, I think, where the name piles came from. It's actually a Latin word, pila, and roughly translated is balls. And that's because they look like small little balls hanging down. If
Yeah.
you've ever seen a hemorrhoid, apparently they look like small little veiny
Yeah.
balls.
Okay, news to me that everybody has hemorrhoids. We're going to be talking about the ones that are symptomatic and causing problems. So, what is the history? Someone will have a history. You kind of mentioned it already. If I think I have hemorrhoids, I'm going to present to my doctor saying these following symptoms: pain, itchy, maybe some bleeding.
Pain, itchiness, bleeding, swelling. People sometimes, when they get really bad, they prolapse down. Sometimes they'll go back in on their own after a bowel movement. Sometimes people have to actually push them back in. They can be extremely irritating, and when they get really severe, such as a thrombosed hemorrhoid, where you get a blood clot in them, they become very hard and extremely painful, and it's life-altering for these patients.
Okay.
Now, are there different types of hemorrhoids? Is there a way to classify them?
Yep. So there's a few ways to classify them. There's an internal versus an external hemorrhoid. The internal ones are the ones I'm talking about, where they start to pull out and prolapse out. The external ones are blood vessels more on the mid to external anal canal that get swollen. The internal ones, we grade them from 1 to 4, 4 being the worst, where they are prolapsed out and you can't get them back in.
Right.
3 is when they prolapse out, but they do go back in, and 1 and 2 are the internal ones that swell and bleed and cause problems.
Okay.
Okay, so you got a history that we just described, and you figure I got to go see my doctor. What kind of things is the doctor going to do to someone who presents with a history of hemorrhoids
Well,
for diagnosis, basically?
Few things. Physical exam is the first thing. It's a key thing. When people present with hemorrhoids, they can have all sorts of different things, right? We need to rule out, especially cancers. That's a big thing. Whenever you have bleeding from the bottom end, you want to make sure that you're not missing something like a cancer. We see so many patients that come to us for hemorrhoids, quote unquote, and then we examine them and we find out there's something else going on, right? Things like rectal polyps, which are sort of precursors to cancers. Those are another common finding that we see that we have to rule out. So physical exam, that will, it'd be a quick diagnosis. We'll be able to get a sense of what grade the hemorrhoids are. And also helps us to rule out those malignancies.
And so this would be like a rectal exam, inspection, obviously.
Yep.
And then do you use any other devices to improve visualization?
Yes, and then usually after that, we'd also want to do some sort of scope.
Okay.
Putting a camera up the bottom end, whether that's a sigmoidoscopy, where we just go up the bottom sort of 30 centimeters, or a full colonoscopy, where we look around the whole colon. That depends on your symptoms, how much bleeding you're having, what type of bleeding you're having, any change in your bowel movements.
Is sigmoidoscopy done like in the office? Do you have to be sedated for something like that, or?
You don't need sedation for sigmoidoscopy. That's a quick procedure, takes 5 minutes.
But it gives a lot of information for you.
Ton of information. It's a great test, and quick and easy. You walk out and it's fine. Colonoscopy is obviously a little bit more invasive, more prep. You need sedation, all that. But both are very good tests.
Okay, to the viewer, please, we're trying to normalize this. Please don't be embarrassed about a hemorrhoid and not go see the doctor, because you just heard there's other things that it could be that are important to find out what it is. We joke about it, we're normalizing it, we're using words like anus, bum, bottom, sigmoidoscopy. He's wearing a hat that says your anus on it. We're just trying to normalize it so you feel comfortable enough to say, hey, I think I got hemorrhoids, or maybe something else. Something's going on with my anus. I should go see the doctor about it. Don't be embarrassed and stay home and suffer with this, because it could be something else that's treatable if caught early enough.
Exactly.
Okay, so now you have your diagnosis. You have a diagnosis of a hemorrhoid, and you've tried the non-operative stuff. We've talked about this before. So water, fiber, changing your diet, trying to avoid straining, essentially, which is the big issue. And now you've got to a point where, like, would you do that for a couple of months? Would you give a non-operative trial for a couple of months, or really depends on the scenario?
Depends on the scenario, depends on the severity. Like there's some like big grade 4 hemorrhoids where you look at that and it's like, well, that's
Doesn't matter.
never.
Fiber's not putting that thing
That's
back
not,
in.
exactly. And so when you get to these higher severity cases, then you're starting to look at more invasive options. And it's important to also note that no matter what more invasive treatment we do, if you're not doing the fiber and fluids thing, the hemorrhoids are going to keep coming back no matter what you do. So I always start patients on the fiber and fluids, no matter what surgical option we're going down, just to make sure they don't come back.
Can you give our viewers a ballpark as far as the number of grams of fiber we're trying to target in a day? Because certainly North American diets are grossly inadequate as far as fiber intake.
Yeah.
What are we targeting?
For women, I usually recommend between about 20 to 30 grams of fiber a day. For men, about 35 to 40 is the ballpark figure. Everyone's different.
Yep.
Some guys are bigger than others.
Sure.
So our dietary requirements change. We have a nutritionist, a dietitian who works with us specifically to talk about these types of issues. So there's lots of resources out there.
And you can get it from your food or from a supplement, whether it's a over-the-counter one or something like Metamucil or Benefiber or whatever. There's lots of choices.
Metamucil, Benefiber, Bran Buds, just psyllium fiber, like all of these are
And
easy
always,
options.
always, if you can get it by your food first, you may have to change your diet. Try and get a diet that's high in fiber. These supplements are available if you can't get there with your diet.
Okay.
So for treatment options, usually the first thing we do is something called banding. Hemorrhoid banding, it's a quick procedure as well. It takes about 5 minutes. Outpatient kind of setting. What we're doing with those is we put a little rubber band at the base of the hemorrhoid. Tiny little rubber bands, you can barely see them. They usually fall off within the first day to 3 days. And what it's doing is it helps to cut off the blood flow to the hemorrhoid, but more importantly, it also causes scarring, which contracts and pulls the hemorrhoid back up to the top of the anal canal where the hemorrhoid's supposed to sit.
Almost like a skin tag.
Yeah.
Can we jump to an image just so that we can get a visual of this? An image of what you mean by internal, external, and making the thing go back up.
Exactly.
So let's look at an image that you're kind enough to bring.
Yeah. So here's a picture on the left side. You have the normal position of a hemorrhoid. On the right side, you see where the hemorrhoids have enlarged and starting to prolapse down. And again, the idea with banding is you want to get those hemorrhoids to get pulled up back to their normal position.
All right. Okay, so that's the first option, is the banding. Okay.
And banding, oftentimes we'll have to do a few rounds of these to get them to fully stick. Whenever you're treating hemorrhoids as well, we all have 3 main columns of hemorrhoids in our anal canal. You never want to treat all 3 at the same time because you can get complications with narrowing or stricturing of the anal canal, which is a devastating complication and it can be quite problematic to treat. So if banding doesn't work, and we've done that a few times, and you're still having issues with either bleeding or prolapse, then we have to look at a few other options. In Canada, usually what we go to after that is surgical hemorrhoidectomy. That's a surgical procedure, general anesthetic, you're fully asleep for that. Basically what we're doing is we're putting you to sleep and cutting out the whole hemorrhoid itself. Again, fairly quick procedure, takes about 15, 20 minutes. The issue with the procedure is it's extremely painful. Patients describe it as the worst pain they've ever experienced
In the
Okay.
post-op period, you mean?
in the
When-
post-op period.
Okay.
You know what's funny is that all doctors kind of say that because we had Peter Inson. He's like, "Oh, kidney stones most painful, even more painful than labor." And then we're like,
said
"Total knee replacement, the most painful thing you've
painful.
ever had." You're like, "Oh yeah, no hemorrhoids."
Hemorrhoidectomies,
So
awful.
this is the thing how medicine works. Like, unfortunately, there are a lot of things that are painful, but are necessary to get through the treatment. Unfortunately.
Yeah.
Okay, so very very painful.
Yeah.
Like for how long are we talking?
2 weeks
Okay.
for it to fully heal.
Yeah.
And so because of that pain, it's not something that I typically recommend.
Okay.
Right, and that's why we really push the less invasive.
Is it a last
options.
resort, essentially?
It is a last resort.
Okay.
And as I said, hemorrhoids serve a function.
Right.
And if you cut them out, they're no longer there. And some people can have issues with leakage and stuff like that afterwards.
So there's some of the complications of this procedure. In
Yeah.
addition to the pain, there's complications such as leakage or incontinence
Yes.
almost.
Yeah.
Okay.
Because of that, there's a few other options that are available. And if you're online, you're reading about these things, you'll come across this stuff. Not all of it is very popular, at least in Canada in our
Okay.
setting, but certainly internationally.
What kind of stuff are we talking about?
So one is a stapled hemorrhoidectomy.
Okay.
That's a procedure where you use a special stapling device that basically entraps the hemorrhoid tissue and excises it.
Like we commonly use for appendixes or colon resection, like that kind of staple? Is that what it is?
Yeah, it's a circular staple device.
Okay.
We use them similarly in cases where you want to join a piece of bowel together.
Okay.
But
Is the stapling thing kind of like banding where you're just trying to constrict it
no,
off?
this completely cuts it all out.
Cuts it all out.
It's-
So it's like a hemorrhoidectomy then?
It's
no?
like a hemorrhoidectomy, but it uses a stapling device.
Okay.
But not as common here. There are complications with them,
Okay.
stricturing and being the main one. And I've had to try to fix a few of those
Okay.
for patients who have gone overseas to have this procedure done.
And that's the nature of your practice, right? You're a subspecialist, so sometimes when things go wrong, they come to you to say, "Hey, can you try to fix it?" It's like a revision
Yeah.
of a hemorrhoid surgery.
Exactly.
Got it.
Exactly.
Is there any role for injections?
Yeah, so there's a few sort of coagulation type techniques, injections, there's a laser coagulopathy, and there's RFA ablation, radiofrequency ablation. These all are trying to do the same thing, where you're putting a little probe or injecting into the hemorrhoidal tissue to cause that the blood in it to coagulate and basically shrink down that
Like a
hemorrhoid.
varicose vein treatment
Yeah,
sort of thing.
it's the exact same laser, like
Yeah.
almost the same probe and whatnot. So they work well. They're not as widely available, at least in our setting here.
Okay. Are they expensive?
They are expensive,
Yeah.
right? They're a few $1,000 to get that done. It's a good option for some people. If you're on blood thinners, for example, banding is not a great option. We can't do banding if you're on blood thinners.
Right.
So something like injection or laser or RFA can be used in those situations.
Okay.
There are situations where it's useful, but at least where we are right now, not as widely available.
So your standard protocol would be non-operative treatment, try to avoid and prevent, then you would consider banding, and then last resort is hemorrhoidectomy. You may or may not try some of those other things.
Exactly.
And on the blood thinner thing, so is it possible, it's important for our viewers, if you're on a blood thinner and you have hemorrhoids, is it possible to experience a serious bleed that can require an emergency room visit?
Yeah. There's I've seen patients who've come in who've required multiple transfusions and urgent emergent surgery
Wow.
to get the bleeding under control. It's rare, but it does happen.
Take home message for our viewers: if you do have hemorrhoids and you are on a blood thinner, you have to be careful and be aware of this and be ready to go to the hospital if you start to get some bleeding that you can't control.
Okay, so let's talk about post-op. What does it look like for these people? I'm assuming they're not booking like a night out with their friends the day after hemorrhoidectomy.
Or a 7-hour flight overseas.
Yeah, for a hemorrhoidectomy, as I said, for 2 weeks, life's miserable.
So you're typically off work, would you say?
You're off work, you're at home.
Hard time sitting?
Sitting's awful, you're kind of lying down, you're doing lots of sitz baths, like
Okay.
Epsom salt baths.
Sitz baths.
That's the main way to help control the pain. pain medication, creams, stuff like that just don't work that well in controlling that kind of pain.
Okay. Any topicals or any like local anesthetics that they can use, or not really?
You can, it just doesn't
work
help
very
very well.
Sure.
Right? Really what comes,
time.
the Epsom salt baths and time is the main thing to control that. For banding, you're good to go that day. You can go to work, it's not that big of an issue. If people are having pain with banding, sometimes you can get that, but that usually means the bands have been placed too low.
Right.
And so banding really shouldn't be painful afterwards.
And people may have looked online, and this we're talking about like the dentate line essentially, right?
Yes.
Where the inner part of our rectum is sensitive to stretch, and then the lower part is sensitive to pain and touch and that kind of stuff.
Yeah. So
what about over-the-counter things? Or before someone goes sees their doctor, you know, I got a hemorrhoid, I'm going to try on the over-the-counter things like Anusol.
yeah,
One of those things.
there's lots of creams you can get out there. There's special kind of pills that you can take, but you know, they're kind of temporizing measures.
Symptom control.
Yeah, right. Which is fine. It you know, gets you to control things until you see a colorectal surgeon or a general surgeon. But you know, again, to really kind of deal with this properly, you know, you'll need one of these other kind of interventions.
I'm assuming another big part of the post-op protocol is staying on the fiber, right?
Yes.
Because like you said, these can come back or it could cause failure of your interval treatment, I'm assuming.
Yeah.
It could cause, I'm assuming if you had a very large, hard bowel movement shortly after you had a big operation, it could tear the repair or whatever.
Yeah, yeah, and again, goes back to what I was saying right at the beginning. Every patient I see with hemorrhoids, I start them on the fiber and fluids right away, because that's what they're going to need to be on forever afterwards.
Okay.
So do you personally take any fiber supplement or do you get it in your diet?
I do bran buds.
Okay.
Put some bran buds, yogurt, a little bit of fruit. Do that in the morning. Do it when I get home.
Yep.
My wife makes granola at home. She throws a bunch of bran buds in that.
Perfect.
We feed that to the kids.
Nice.
Yeah, the whole family's on it.
We're practicing what we preach. When we talk about fiber, we're just not saying it. We actually, all of us do monitor how much fiber we take in.
Yeah.
And we do things about it to keep our fiber up. So if we're doing it, you got to do it too.
Last thing, we always talk about complications or risks and complications of the procedure. So obviously there are the inherent risks of any type of anesthetic or sedation. But what about specifically the procedure? So the acute complications as well as the long-term complications that we're kind of hinting at before.
Yeah.
So acutely, what would be the risk?
I mean, yes, as you said, all procedures have risks.
Yep.
For banding, you know, you can get bleeding afterwards. You can get infections from the bands. It's very rare, but these infections can be quite serious. And you'll know that if you have fevers, pain, sometimes difficulty urinating. So if you have any of these symptoms after a banding procedure, I always tell my patients, come back to emerge, get it checked out. Sometimes we actually have to remove the band.
Yep.
You know, there have been some cases as well of quite significant bleeding, again, where patients have had to come back to emerge and have that dealt with. For the surgery side of things, really pain is the biggest thing.
Okay.
But again, bleeding after procedure, infections in the area, they're rare. But as you're talking, the main thing that we're worried about is some level of incontinence, urgency after a big procedure like that. Incontinence is rare. It's quite hard to damage the sphincter muscle when you're doing a procedure like that. But you know, people can feel some issues with urgency or leakage after a procedure like that.
The infection one surprised me. I mean, I'm amazed that there's not more
It is-
infection.
it
You've
is
got,
wild.
like, the anus is an incredible organ because if you have bleeding anywhere else in your body and you rub feces on it, you're going to get an infection.
Yeah.
Now you've got bleeding and feces is passing through it on a daily basis, and infection has happened, but so rare.
There's so much blood
blood
flow to
supply.
the area that it just
It's incredible.
It heals itself.
Incredible.
Okay,
so
now
those
you
are
know.
some-
That's it.
yeah.
That's a great summary.
Yeah. Uranus, is it called Uranus now or Uranus still? The planet, I mean the seventh
I
planet.
have no idea.
I thought they changed it to Uranus.
And
And I'm like,
people
what-
didn't want to say anus.
Yeah, and
Oh,
you put the word urine in and you took out the word anus. Those
so-
astronomers.
so
How's it any
20
better?
One or the other.
How's it any better?
Oh man. Okay. Well, now you know. Please leave a comment if you had an experience with hemorrhoids or with a surgical procedure, good, bad, anything. Please share it because it will help other people make decisions about their hemorrhoids. If you like this video, please like it. Subscribe to our channel. Check out our other long-form content.
And remember, you are in charge of your own health. Thank you so much for that.
Thanks for having me.